Good afternoon, everybody, and thank you for joining us for Banyan's Readmission Prevention Strategies Best Practices That Work webinar. My name is Eric Preisler, and I'm going to be your live moderator for the day. This is going to be a pre-recorded webinar from one that we did earlier in our series. So you're going to hear the voice of Eva Fuyan, who is going to be the moderator during the recording. And then our main presenter for the day is going to be Linda Rittermeyer, who we are going to introduce just a bit later. So just a couple housekeeping things before we get going. Please unmute all of your computer speakers. If you can hear me right now, we are off to a pretty good start. If you have any questions for us, you can see the question box on the right side there with a little hand pointing to it. Feel free to type any questions that you would like into that question box. We are not going to do a live Q&A session at the end of this, but we will respond to all of your questions via email after the webinar. Also, we're going to have live interactive polling questions during the presentation, just to kind of get a feel for how we're all doing fall prevention, some of the issues, problems, things that we're doing across the nation. So I will jump in right before the polling questions. I'll let you know that it's going to be live. These are completely confidential. We can't see any individual results, but we will share the results as a group so we can all get an idea of what we're going to be doing. So without any further ado, I am going to turn it over to the recording now.
Now I want to introduce the agenda here. First of all, we'll have introductions, and like I said, I'll introduce our main speaker. And then we're going to talk about the landscape of readmissions right now in healthcare over the last few years as we've tried to reduce readmissions. And then we'll go into those best practices from our clients and what they've done to decrease readmissions. And then we will talk about solutions, results, and statistics because we want to see if people are really making some progress here. And then at the end, like I said, we're going to have this discussion time, Q&A, where we have questions and answers, and we'll open it up so that people on the phone can actually talk with each other. So now I want to introduce our main speaker. So Linda Rittermeyer comes to us from HCA. She was a former CNO at an HCA hospital. Before that, she began her career in pediatrics as a pediatric neonatal nurse, and then progressed along until she eventually was a CNO at HCA. She came to BANYAN about a year ago. She has her RN, a BSN, and an MBA. And I'd like to turn it over to Linda now. She's going to talk a little bit about the readmissions landscape, where we're at, what's happened over the last few years, and then maybe some industry programs that are going on to reduce readmissions. So, Linda.
Thanks, Eva. So, good afternoon, everybody. We're going to jump straight into this and just talk about some statistics. So, just to kind of level set, this is what it looks like across the industry. So, in 2010, CMS implemented their Medicare Hospital Readmission Reduction Program. And basically what that did is hospitals were penalized for unnecessary hospital readmission. Specifically, what it was designed to do was to incentivize hospitals to take strategic action in reducing expenses and unnecessary hospital readmission. And these are things that we deal with each and every day. And it's still a big problem. I mean, if you're talking about in 2010, they started implementing this, and now here we are in 2018 and still talking about it. And why are we still talking about it? Because we're talking over $500 million, $528 million, as the slide says, of penalties that have been in 2016 and future penalties that are coming up. And they're all associated with readmission. And we know that the 3% maximum penalty has increased from what it previously was. And what do we say all of this is from? Well, ineffective discharge processes, planning, med recs, handoffs, and insufficient patient education. And according to CMS, so not that $528 million number isn't big enough, according to CMS, $1.9 billion, yes, with a B, worth of penalties when you look at all the other pieces that it costs us. That's what it costs our healthcare facilities across the industry together. So all cause 30-day readmissions, that's a very common term. We all know it. 20% of those people, of our patients, are being readmitted after 30 days. It jumps to 40% when you spread that out to 90 days. And these are unplanned readmissions. So when we're looking at this, and what are some of the reasons? So symptoms worsen after we do a discharge. We really try to get our patients in and out as quickly as we can. Adverse effects of the meds. So a patient might start a new med or whatever, and then by the time they go home, you don't see those side effects until they get home. Unaddressed test results. So a patient's going to be discharged before we even get test results. And then the follow-up from those test results, sometimes that gets lost in a big old black hole. So this is more important than just in one department. As you can see, this is the titles of some of the participants we have on this WebEx today. It crosses all our different disciplines, if you will. So what we're looking for is a workable solution that's consistent and replicable. And when we talk about, not only are we across all these different disciplines, but we personally at BANYAN, we work with both rural hospitals, large corporations, for-profit, not-for-profit, standalone entities. So not only are we crossing all these other disciplines, but we cross every kind of hospital that there is out there. I kind of liken this to putting your finger in a dike. We think that we have the answer to something. We put our finger in there. We're like, yes, we're working well, but then something pops someplace else. So it can be quite frustrating.
This is going to bring us to our first live polling question of the day. So again, these are completely confidential. We can't see any individual answers, but we would like to get an idea for the group, just to share with each other on kind of your thoughts and ideas on readmission. So our first question is going to be, what are your biggest causes for readmissions currently? The need for standardization discharge process, preparing patients and family for post-discharge, education to patients and families about medications, communication and coordination post-discharge, or not sure and other. And I know the facility that I worked at, a lot of ours ended up being in the education, patient education realm, was where we saw a lot of our discharges. And I would say even in the communication area, we really struggled with transfers interdepartmental and just making sure that continuity of care was consistent, because sometimes it was great and then other times we kind of fumbled it a little bit. So it looks like we have about 65% of the vote in. We'll give you guys about 20 or 30 more seconds to answer here, and then we'll go ahead and close it and share the results. So it looks like communication's definitely one of the higher ones. All right, we'll go ahead and close that poll now and share kind of what we've seen and what we're all looking at. So again, communication and education are the two highest priorities for what's causing this readmission. I think that's pretty common across the spectrum. Some people are in the not sure category, and hopefully this webinar, the rest of this webinar, will kind of help pinpoint some of those pain points that really cause readmissions and some of the things that we need to be focused on, especially communication being the number one thing. So with that being said, we'll go ahead and turn it back over to the webinar.
In 2018, the Health Research and Educational Trust came out with several suggestions, bundles, toolkits, whatever you want to call it, about how to improve readmission rates. their goal is 12%, a reduction of 12% of all-cause 30-day readmissions in 2018. So when we looked at this, I did some research. I read some of the research on each one of these, and I think that there are probably things that most of you have even seen. Read a transition care program, boost, those types of things. And I know that these are some bundles and toolkits that I have used in the past. And again, I'm going to go back to that finger in the dike. You think you have the answer, but then something else happens. But there's something pretty consistent through all of this. And if you look at what we have underlined here, there seems to be a pattern. Whether it says care transitions, transitions of care, that's the piece that's consistent through all of this. So hopefully you guys have seen some of these toolkits and bundles. And so what do they suggest? What they suggest is root cause analysis. We've all done root cause analysis. We've all tried to create those standards, delivered enhanced services, and really work with our internal and external stakeholders. But at the end of the day, what we really are looking for is to create that always event. We all are very familiar with never events, but what do we do about creating an always event? Our clients have been able to do that, and as Eva said at the beginning, we're going to show some best practices that we have in those always events and readmissions, but there are other things that are out there, just like we just talked about on the previous slide, the HRET. So, what are some of the methods that they talk about or that you've looked at in your own hospital? We all know the PDCA and how we do that. Those of us who are nurses or clinicians, you know the nursing steps in the nursing process. And then smack dab in the middle of that is how do we use our problem-solving process from step to step to step. In my own history, we've done a lot of Lean Six Sigma processes. We've done KPI boards. But how do you make that continuity of care stick? So as I said before, you know, you solve one problem, and like you said in the survey, there's a lot of communication. There's a lot of handoff. How do you make sure all of that step by step by step becomes an always event? So I couldn't always guarantee that each step was taken care of in the whole picture of it. So sometimes it was frustrating because you had to do these PDCAs, the nursing process, problem solving for each individual step. And again, by the time you got to the end of that problem solving, the first problem that you thought you had solved, you already sprung a leak on.
And so our second live polling question of the day is going to hit on the all-cause 30-day readmission rate. So what is your all-cause 30-day readmission rate? And again, this is completely confidential. You know, the national average tends to hover around that 20% range or so. At my facility where we were working, we had struggled with that for a little bit. We stayed kind of around that 30 to 33% range for the most part, and we had tried everything. You know, we had gone through all the policies and procedures and tried to streamline as much as we could, and we were just still fighting with those, you know, communication issues like we had mentioned earlier in the slideshow. So it looks like we're getting some votes in here. Just over 50% of the people have voted, so we'll give you guys a few more seconds here, and then we'll shut her down and share the results. So it looks like the majority of the people are kind of following that bell curve there and hanging right around that national average, 10 to 19%. It's really good to see a lot of people well below that national average, and you know, hopefully we can pull some stuff out of this webinar today to make that go even lower, because ultimately we'd like to be in the 0 to 9% and ideally closer to 0. So we've got about 70% of the vote in, so we'll go ahead and close that down and share these results here. So as you can see, most of the people, 44%, are in that 10 to 19% range, which is right about the national average. It's good to see, 22% in that 0 to 9%. That's fantastic. And then that 20 to 29% range, we got about 28%. So, hopefully that we can glean some stuff out of this on communications and ways to create those always events that can, push us all down into that 0 to 9%, kind of the gold standard where we want to be. So we'll go ahead and turn it back over to the recording now. Thank you all for your participation.
So, of course, when you look at this slide, you might recognize what your piece in this puzzle might be, but then those dotted lines, it's between those dotted lines where those gaps happen to make sure that we have an always event. And it's just because we have different providers with varied roles, but who owns the whole process? Who makes sure it happens from start to finish? As we asked before, as we said before, this crosses all the boundaries because it's in your internal and external stakeholders that are touching our patients to make sure that we create this always event. So what does it look like? So here at BANYAN, with our partners, what we are able to do is to help them create this always event by having this smart screen, taking all those pieces that you saw scattered previously in a disparate system, and you're able to share information no matter where you are, no matter at what time, so that you can create that always event for your patient. Now, making sure that it all comes under that quarterback is really the key to it. So a picture's worth 1,000 words. So I'm going to show you a video, which is probably worth about 10,000 words, so you can see what we're talking about.
Okay, so we're going to show you this video, and like I said before, unmute your computer so that you can hear it, and then don't worry if it doesn't come through very good for you based on whatever the bandwidth is that you have or your firewall, or maybe think that GoToWebinar might have a problem with. We're going to send you a link to this later so you'll be able to play through it, but we're going to go ahead and play it. Sometimes some people have had a little bit of, it's kind of slow, but we'll get you a link and you'll be able to view it in full later. But it's a short video. We just want to show you what our clients and what our hospitals are using to create always events.
At BANYAN, patient care is at the heart of everything we create. Introducing BANYAN Care. BANYAN Care is designed to make the patient experience more positive, while empowering nurses to truly deliver the best bedside care possible. This system is revolutionary. It enables healthcare professionals to interact with patients and access their information in real time from anywhere. Here's how it works. The heart of BANYAN Care exists right where care is delivered, the patient room. The system integrates technology to the TV in a typical patient's room. We add a touchscreen computer, communication camera, fall prevention camera, speaker, and a microphone.
Hi, Mr. Avery. This is Anna, and I'll be helping with your care today.
The touchscreen is placed below the TV, and the TV itself is used as a secondary monitor for sharing content. You have the ability to bring all the content and systems that you already utilize together in this one screen. Electronic medical records, images and diagrams, notes, and other content. Patients and their family members can simply tap the screen to have instant access to their nurse. Providers in the room can use it to perform rounds, mentoring, or simply communicate with a nurse. Nursing staff is notified as to who is calling in, so they can prioritize accordingly and enhance workflow. When a patient or family member taps the screen, it defaults to audio only, so the provider can make sure it's an appropriate time to use the camera. Now, the nurse can pan, tilt, and zoom the camera to check on different visual aspects of the patient room. They can pull up documents or images, make notes and visual references for patient education, From one screen, providers have access to all medical information necessary to make rounds, conduct admissions, discharges, and deliver patient education. Multiple providers can even join in simultaneously and interact with the BANYAN application remotely. When it comes to patient education and communication, our tools enable healthcare professionals to interact with patient information in a whole new way. For example, drawing right on the screen to highlight things of importance. BANYAN Care transforms patient satisfaction by allowing hypercommunication and collaboration between nurses, hospitalists, pharmacists, doctors, and families right in the patient's room where patient care is delivered. We are BANYAN, and we believe in healthcare transformed.
I want to kind of break it down for you here. So what we do is we virtually integrate a patient room so that providers, nurses, and a care coordination kind of quarterback can enter the room virtually along with your bedside staff. And when they're entered virtually, they can also bring in any application that you have, and that screen can be shared anywhere virtually. So we start with the patient room, and we virtually integrate that patient room. And then we have a virtually integrated caregiver station. So this might be that quarterback that's guaranteeing always events. And so if you've decided that every discharge has to have these 20 steps, that person makes sure that in every discharge those 20 steps happen by going into the room and tracking that information virtually for you. And then also they might be in charge of doing discharge calls or setting up that follow-up appointment. And then you'll see that we also have a virtually integrated physician or a virtually integrated pharmacist. So now your pharmacist, your physician can come into the room virtually and do extra education, can make sure that they understand if the patient knows what they should do and their family knows what they should do. They can also check to make sure that they have all the tests back. You know, one of the comments we got was that sometimes patients are discharged without really getting all their tests back from the lab, and so that can cause some readmissions as well. You know, we had a comment here just a minute ago on our first poll question. If you remember, there was an other, and so someone was kind enough to type in what the other was, and so this person said that their biggest reason for readmissions was because providers not understanding what admission diagnoses are. And so by having this system, you can actually make sure, the nurse can make sure, the quarterback or a case manager can make sure that the physician understands the original admissions, and you guys are coordinated and have always events around this type of admission. We are going to always do these things to make sure that we don't get those readmissions. And so you can see that no matter where the physician is, they could be at another hospital, it could be the pharmacy downstairs or across town. You can make sure that people are entering virtually, and you can have one person that is checking off and making sure that every single step that you have is happens with every patient before they leave your hospital.
This will bring us to our final polling question of the day. So in transitions of care, how does your facility guarantee these always events that we talked about in preventing readmissions? And so, you know, a lot of things that we did at my facility that I was at, we outsourced a lot of it. So we used a lot of outside people to make sure that things were getting done. And sometimes the accountability wasn't always there with those outsourced people. And again, that's something that we definitely struggled with. And it's kind of all these polling questions, you know, for me personally, they all kind of tie together in why our readmissions were higher. And this kind of is the final bow on top of it that made me realize, okay, maybe there's something that we could be doing differently to, you know, decrease those readmission rates for our facility. So we'll give you guys about 20, 30 more seconds here. It looks like about 50% of you have voted, which is fantastic. Thank you all for jumping in on that. I'll give you a few more seconds here. Looks like most people put it in the hands of the case management. So about 50% of you right now use your case managers to guarantee those always events, which is fantastic. All right, we will go ahead and close it now. We have about 70% of the vote in. So as you can see, most of the put it in the hands of the case management, which is, you know, very common across the industry. All the people that we talk to and our clients, most of them have used case management before the implementation of this quarterback nurse. Looks like about 24% of you put it on the nurses, which they do have the direct contact with the patient. So that's sometimes seems like the most logical thing, but it's just one extra thing that gets put on their plate, you know, more administrative duties, that type of thing. So thank you all for your participation, and we'll go ahead and turn it back over to the recording now.
So as we promised, I know we've been doing a lot of talking about other opportunities that are out there, other studies using different processes, PDCA, and some of the things that we've all tried in the past. But now we're going to get down to where we have some results from our personal clients. So these are 4 key areas. And if I remember right, in one of the poll questions, it was communication. A lot of what we're showing right here is really taken away and increased, made better, whatever terminology you want to use, by having that quarterback help with that communication. So statistically, it shows that 36% of our staff our staff spends 36% of their time doing administrative work, not focusing on their patients, not focusing on communication, and who needs to know what they're doing or where they are to create those always events. So as our video showed, what if you could give back that 36% where you could increase the focus on patients? Would that increase your patient satisfaction? Would the education and better communication and teaching of the patient lower that length of stay? Also lower that admission? And if you're clear in the communication, your external stakeholders, what if that communication between your internal and your external was streamlined, well communicated, everybody's on the same page? So for me, as a previous CNO, if I could make sure all of that was done inside of my 4 walls, and that we were able to communicate that to wherever that patient was going, of what was expected and what we could do for them, I think that would really have reduced some of my readmission rates and made us all happy. Plus, the other piece to this, a side piece, almost, if you will, but something that we all focus on, is our HCAP. So our clients have been able to increase and improve their communication on their HCAP between doctors and for nurses, and that little piece at the very bottom that we all struggle with, transition of care. They've all made great strides to bring those up to the green. So what we're going to do is we're going to talk a little bit about St. Anthony's, which is one of our first partners that we've had. And because of this, with this hospital, we use them because they've been with us for the longest, a couple of years. We have other hospitals, like I had said before, large hospitals, small hospitals, we're across the continuum. But St. Anthony's really wanted to use our platform to help decrease their readmissions, their length of stay, and improve their HCAP scores. So Eva's going to go over their scorecard here in just a minute. But what I really want to point out was that the study showed that we wanted to decrease readmissions by 12%. They've been able to decrease their readmission rates by 35%. So
initiatives and also called Centura. They're in Denver, Colorado, just outside of Denver. They're a level 1 trauma center. They have a total of 224 licensed beds. And they started with a 36-bed care innovation unit, they call it. It was half of one floor. And they really wanted to focus on, if you know, in Denver, they get a lot of patients off of the ski hills, and so they have a real high acuity rate. You know, they have like the tough cases. They actually were the first life flight hospital in the country, and so they dealt with tough patients. We kind of wanted you to know that because that, you know, you can get a lot of readmissions based on that. So it was a tough place to start, but that's where we started. So I'm going to go into their results right now. So when they set their goals, the first column I'm going to talk about is that team goal. So they wanted to really focus on the readmission rate, and so they set a goal of 10%. And then they wanted to also decrease the length of stay by 11%. They thought if they did this, they could also reduce falls and falls with injury, and so they set a goal of 35%. And then they were doing really well with central line infections and catheter-associated urinary tract infections, and so they didn't want that to go up at all. So they started with a baseline in October to February, October 2016 to February of 2017. And so their baseline on readmission rate was they had that 13.9% were readmitted within 30-day all-cause readmission. And what they actually saw was they decreased it by 37% down to 8.7% readmission. So they were under 10%. So they actually were able to beat their goal and improve their patient care. In addition to that, they decreased their length of stay. And if you remember, they wanted to decrease it by 11%. They actually decreased it by 12.6% and went down from a 3.41 days of length of stay down to 2.98 days. Now, probably one of the most astounding statistics, though, was the falls and falls with injury. So on average, they had set that goal of 35%. They actually decreased it by over 75%. They went down from 2.78 falls in 1,000 days down to less than 1, so 0.69 patient falls over 1,000 patient days. So that was pretty astounding. They were able to keep their central line infections at 0, their catheter-associated urinary tract infections at 0. And then one of the things that was interesting was the call light response time also decreased from 1 minute 23 seconds down to 51 seconds. So it's really an exciting story for them. And this was the 6-month pilot. And if you remember, it was on 37 rooms. And so now they're into expanding across other departments and other floors because they're seeing these kind of amazing results. I want to go next then into the HCAP scores, as Linda kind of brought that up. So the 7th floor was that care innovation unit. They started, and this is the overall rating question, the top box overall rating question. And when they started, it was at 50%. And when they implemented the program, then they have actually climbed up to 100%. So for 1 month time frame in that April of 17, 100% of their patients gave them an overall rating of a 10. And so that was amazing. Now you see it dip here, so you say, whoa, what happened? Well, they had to pull that virtual care coordinator off of being the quarterback and put her on the floor because they were short-staffed. Okay, so then they hurried up and got her back into the virtual nurse station, and they went back up to that 100%. And anytime you pull them off of being that quarterback, you can see that your scores go down again. But overall, during this whole experience then, from February of 17 to January of 18, the overall rating went up to 46%. So, that's an amazing number to be able to effectuate that number. And then I'm going to talk a little bit about communication between the nurses, doctors, with patients and families. Communications with nurses went up 52%, 55.2%, and then communications with doctors went up 31.4% over that year time. And so you can see that those two questions are highly correlated to the overall rate and the would recommend. And if you can increase those two scores, you can absolutely see an increase in your overall rate and your would recommend questions at the end of the survey. The other one was the responsiveness of staff went up almost 30%. So you can see that a program like this doesn't just affect readmissions, but it's a cross-hospital, cross-continuum program that allows you to really effectuate care in a different way and give your caregivers time back where they're not doing administrative work because you've centralized this under one person on the quarterback. And then the other caregivers get 36% of their time back so they can spend more time with your patients. They can spend more time doing what they went into healthcare for. And so our program, when we get a little farther along here, we're going to show you St. Anthony's in action here in a second. You're going to see that actually you save money on this program, not only by getting better quality metrics, but when you give 36% of your time back to your nurses and your caregivers, you actually can reduce overtime and reduce travelers because your valued, most talented people can be on the floor more. So I'm going to turn this back over to Linda now. She's going to talk a little bit about this video before we launch it.
So thanks, Eva. So this video was first shown at AONE this past April. This was CHI's video. And as you'll see in the video, Kathy Sanford talking about how they utilize their partnership with BANYAN. Shannon Dennehy, Linda Goodwin, and Sue Schalke all did this podium presentation. So let's watch this video so you can see what BANYAN does and how BANYAN helps their partners.
At a time when nursing shortages are often cited in the news and healthcare is under tremendous pressure to improve quality and the patient experience, innovative new care models are needed more than ever. One way that Catholic Health Initiatives is addressing this need is to leverage the use of technology along with skilled patient care. Catholic Health Initiatives has introduced its virtually integrated care model, trademarked as VIC and often referred to as virtual nursing.
When we first launched our very first VIC pilot, we considered ourselves pioneers in the field. We were really fortunate in that the Catholic Health Initiatives Board of Stewardship trustees supported innovation and that our original funding came from CHI. What Catholic Health Initiatives believes is sometimes you have to jump into totally new ways of doing things if you're going to provide the very best in care for now and in the future.
Virtually integrated care incorporates a team approach. 3 distinct team members make up the core patient care team. 1, the bedside team member, 2, the technical nurse, and 3, the virtual nurse. Other nurses, physicians, dietitians, pharmacists, therapists, environmental specialists, social workers, and staff make up the larger team. The bedside care team member is responsible for ensuring the comfort of the patient and that his or her personal needs are addressed. The technical nurse performs nursing procedures such as IVs, lab specimen collections, wound dressings, and daily hands-on assessments. This helps ensure that documentation in the electronic health record is accessible in real time for the virtual nurse and other members of the virtual care team. The virtual nurse communicates face-to-face with a patient through a 2-way television screen. This nurse is physically located in an on-site technical hub and has the patient's vital signs, records, and lab results at their fingertips. This clinically expert nurse monitors the patient's current status, ensuring interventions are appropriate, timely, and coordinated. The virtual nurse answers patient call lights, provides patient and family education, and performs admission and discharge planning. They also direct the hands-on activities of the bedside team. Key procedures are in place to protect patient privacy. For example, the camera connecting the patient to the virtual nurse is not turned on except when the two are communicating, unless patient safety needs dictate otherwise. In fact, if the nurse enters the room virtually, a soft doorbell chime announces his or her impending arrival. Though patient privacy is always a priority, it's comforting for the patient to know that their virtual nurse is only a button push away, providing a new level of access to their nurses.
Some of the patients that I've talked to are patients who've had several hospitalizations, so they're able to compare how it was before they were on a VIC unit and how it is now that they are on a VIC unit. And they have expressed great comfort at being able to talk immediately to the nurse. They also like the fact that the nurse comes on the screen when the physician's in the room, so that after the physician leaves and the family comes in and the patient's trying to remember what is it that the doctor said to me, they can call up that virtual nurse who was in the room at the time of the visit, and they can have a very good in-depth discussion about what the physician said and whatever else the patient would like shared with his or her family.
There will be some form of virtual care within the next 10 years. I would venture to say in every hospital bed in the United States. It is an opportunity for us to really be on the leading edge of that, and our team does understand that. They're very excited, and they are experiencing it in a live environment, so they see the difference that it makes in the life of a patient, in their care when they're in our facilities. And so I think that keeps us moving forward. It encourages us, lets us know that we're moving in the right direction, and it's been a very special experience. Very proud of all of our team members.
Noteworthy is the benefit of increased teamwork and work satisfaction. Catholic Health Initiatives views virtually integrated care as a viable solution for the nursing shortage, an approach that maximizes available nursing resources while providing patients with safe, high-quality care and experiences. It's a key innovation on our journey to provide care that addresses the whole person, is effective and affordable. Together, we are making a difference, one patient at a time. Catholic Health Initiatives.
So this will conclude the recorded portion of the webinar. And I just wanted to quickly give you all a little bit of background on who we are as BANYAN. So we are currently in 36% of the top health systems in the U.S. And actually the facility that I worked for is on this list as well. I became familiar with them through the laboratory and OR spaces. And they began to branch into the acute care spaces with some of the virtual technology that we presented there. And you know, the stuff that we're doing here is pretty amazing, pretty groundbreaking, and it's very patient-centric and nurse-centric. And that's really our philosophy here, is we want to be good to our patients, and we definitely want to be good to our nurses, because they're, you know, the ultimate caregivers in all of this. So we want to thank you all for joining us today. And we are going to be doing a live Q&A session, but again, if you want to enter any questions into that question box on the right, we'll keep this up for a little bit so that you can ask us any questions. We'd be happy to send you an email or to schedule a quick phone call to go over any questions you might have over this webinar. We will be sending out a copy of this presentation and the 2 videos that were shown in there, so that you can review it and talk to your other team members about some of the stuff that you saw here, and hopefully implement some of this stuff, because, you know, readmissions is something that's really important. It doesn't just affect the bottom line, you know, it affects our patients and our patients' families. So the more that we can start being proactive about this stuff and start increasing that communication, you know, start increasing those transitions of care and making them better, the better off we're all going to be. And so here's my contact information is there on the bottom, and Linda Rittermeyer's is at the top there. please feel free to reach out to us at any time. We would be happy to answer any questions or have a conversation with you on some of the stuff that we've seen throughout the years and some of the stuff that we know have worked, and talk to you a little bit more about some of the case studies that we've conducted around this virtual technology and how it can work in your facility. So we do have a few upcoming events, which I'm personally very excited about. We have a fall prevention webinar, which is a continuation of this series. We're going to talk about how this virtual care can work within a fall prevention program, and how it can reduce falls with injuries and increase the reimbursements from CMS. We're also going to be at the Magnet Conference next week, which we are very excited about. We're actually going to be presenting case studies there, and we're having one of our clients in the booth on Wednesday, October the 24th. One of our clients is going to be in the booth. So we would love for any of you guys who are going to be there to stop by and join us, talk to us for a little bit, see some of the stuff that we've been doing, talk to one of our partners and our clients about how she implements this virtual technology in her hospital, and some of the stuff that she has seen with it. And we are going to be in booth number 1375 for that. We are also going to be conducting more webinars in this series later this year and throughout next year as well. So please visit our events page at any time at banyanmed.com/events, and you can see what our next topic is. These are going to be monthly going from here on forward, and we're really excited to present you some of the hot button issues and how some new technologies in healthcare can kind of fill some of those gaps that we're seeing today. So thank you all very much for joining us today. Please follow us on all of our social media sites that we had up there at the front. We're on Facebook, Instagram, LinkedIn, Twitter, pretty much all the major ones. But again, thank you for your time today, and we'll give you some of it back, and have a wonderful rest of your day.